It's no secret that cancer is a global issue. 28 million people living around the world are affected by this disease. And in all of our communities, it'll look and feel different.
Cancer is a growing problem. It is increasing in its scope, especially in the developing world.
It's a problem particularly of the poor because of their vulnerability to acquire and manifest the disease, as well as their inability to access care.
This year alone, 5 million people will die as a result of cancer in developing countries. And these very countries are the least equipped to deal with this burden.
It's soon to be the #1 killer of human beings on this planet through all the continents. And if we ignore that, it's irresponsible on our part.
In 2010, we decided to form the Global Task Force for expanded access to cancer care and control in developing countries.
It was convened by a group of institutions at Harvard University, the Harvard Global Equity Initiative, the Harvard Medical School, the Harvard School of Public Health, and the Dana-Farber Cancer Institute to unite global health, public health, and cancer communities through leaders to think of novel solutions to be able to expand cancer care and control for populations living in resource-constrained settings in lower and middle-income countries around the world.
What we're trying to do is look at each of the different parts, the policy part, the financing part, the access to medicines part, and show what the evidence is, show what can be done, and identify the key levers to move forward. We talk about health system strengthening, which is to get the different building blocks of the health system as effective as they can be. Health workers that are trained, funding that's available, pharmaceuticals that are supplied. But the real test of a health system is whether or not it is delivering the prevention and treatment for all of the problems that affect the population.
The health systems in developing countries are challenged by the dual burden. You still have infectious diseases. In addition, now you have these new challenges emerging in the form of non-communicable diseases. So the health system is burdened with simultaneous demands. As a result, the priority is often given to the pre-existing problems, and non-communicable diseases have not featured as yet in the health system response.
The health systems have to cater to the needs of all the people, regardless whether those needs we classify them as communicable or non-communicable.
I've been a medical oncologist now for over 30 years. I think we've learned a lot from the treatment of infectious disease in some pretty challenging areas where medical resources are either slim or non-existent.
Many of these things don't need to necessarily cost more money. For example, training doctors and nurses in how do you collaborate as a cancer care team to consult one another on how to treat that cancer patient.
Cancer is very expensive. The cost of drugs are absolutely prohibitive. Everyone is poor against cancer, especially in the developing world.
The pharmaceutical companies need to be able to manufacture and sell drugs at affordable prices so that they can in fact be used in these areas. And developing healthcare teams that can be placed in an environment where they can in fact be successful.
6 million people are now in antiretroviral treatment for AIDS. What we have done for AIDS, we can do for cancer.
I think it's important to know that in hospitals in developing countries, patients are presenting with cancer, they're getting treated, and many of them are being cured. Now the trick is to get those stories out so those in their families and their communities can see that cancer doesn't need to be a death sentence.
So having a champion in the community, a person who's survived the disease, is, yes, an inkling of hope, but also the truth and the evidence that it's worth going through the treatment and seeking care.
Well, we know that this disease takes a personal toll on families and communities, but it also takes a financial and economic toll. We all have to share in that load, and in order to reverse that curve and stop the slide, we have to act.
This task force is working to put cancer on the global agenda so that the decision makers, the ones that will influence international funding, will finally hear that we need to put a new label on cancer that says urgent action required now.
Quality care for cancer patients is possible in any country. We need to mobilize, we need to apply the resources, and we need to put together the kind of commitment that will make it possible.
Yabanye Francine, mfite imyaka 15. Undi kuntu nge natangiye ndwara, nafashwe mfite akantu k'agasebe mu kanwa. Nari mfite uruntu rugera hano, ku buryo babonaga ndi umuntu ndembye nenda gupfa, maze ubundi banyitaho banshakira imiti.
أنا اسمي عبد الناصر. بعد 6 شهور نزل وزني تقريبا من 80 كيلو ل 60، وال6 شهور التانيات نزل من 60 ل 49 كيلو. فرحت عند الدكتور فحصني بطني، قال إنه معك جرثومة، إنه هذا الإشي تراجع فيه دكتور أورام دم. ففاجأني بكلمة سرطان الدم. طبعاً أنا يعني ما عرفتش أولا وين أروح.
Yo me llamo Hermila y me diagnosticaron cáncer de mama. Cuando el doctor me dio la noticia, pues me asusté, me espanté. Yo nada más había escuchado que las quimioterapias eran muy caras, pues no tenía una idea ni cuánto. Con el sueldo que gana uno, no ajustaría para pagar las quimioterapias. Yo dije, pues me voy a morir.
It's clear now to everybody who's paying attention that chronic diseases, non-communicable diseases like cancer, are accounting for most of the world's deaths. 60% in the developed world and 80% in the developing world. And I think that they can be treated, they can be prevented, and they can be addressed in some of the toughest places around the world.
It's clearly a global problem, and yet it's different from country to country. And there are many parts of the world where there are no health systems, so there's no way of educating people about basic prevention that will avoid a lot of cancers. It needs a global response.
One of the things that the international community can do is to stop saying or suggesting that cancer is not a ranking concern in the least developed countries. It is. This is a serious problem right now. It has been for a long time, and we have some tools that could be used to address cancer in developing countries, and we need to deploy those tools.
mu Rwanda nta kundi kuntu twabifata kuko iyo tuyifashwe hari benshi n'abamara kuko
iyo numvise kanseri numva nihebye kuko nta muti igira niba no kurwara sida aho kurwara kanseri.
I moved to Rwanda in 2005, about 6 years ago. We were invited by the Ministry of Health in Rwanda to come and work in a couple of rural health districts that at the time didn't have functioning hospitals. There was 400,000 people and not a single doctor. Originally, we moved to this abandoned hospital.
Muri jenoside, muri 1994, ibitaro byarasahuwe, birononekara ku buryo bitashobora gukorerwamo bidasanwa.
After being there for maybe a year, we began getting children with cancer. I didn't go to Rwanda expecting to treat cancer, and it wasn't on the top of my list of public health problems.
Cancer starts to emerge as a concern in a country like Rwanda because people start to survive of malaria, HIV, tuberculosis. So you can see that people didn't get time to develop their cancer.
Our first case was a girl whose name was Francine.
yagiye mu bitaro mu bavuzi ba Kinyarwanda noneho birananirana banzana akagenda agashaka ahantu aguza amafaranga kugira ngo nkundengere inaha.
Francine had this enormous tumor growing out of the side of her face. Eventually, we were able to send a biopsy to CDC lab and found out what type of cancer it was, and it was a rhabdomyosarcoma. This actually was a cancer that had a relatively good prognosis. I didn't really have a model in my head for how we would address this. We were in this very rural hospital. I just didn't think it was something we could do in our setting. Her tumor got bigger, and we felt that she would definitely die without treatment, but I didn't have a precedent for it.
In 1997, cancer treatment was not great here in Jordan. And as you know, cancer knows no mediocrity. You either get great cancer treatment or really don't bother.
In our part of the world specifically, people are still terrified when they hear the word cancer.
وموت يعني بداية يعني خلص بداية النهاية للإنسان.
ودائما أسأل الله إنه يبعد عنا ويجنبنا إياه عما هو مرض مخيف.
وأنا من أبناء قطاع غزة المقيمين بالأردن. أنا شغلي بالوسط التجاري على بسطة أبيع يعني أطلع مصاري، فلما أنا مرضت بعت البضاعة بالمستودع عشان أدفع للمستشفى الآن.
When we first started working at the King Hussein Cancer Center, we obviously focused first on treatment. Because if we were to show that people can survive cancer in the first place, then you really have a chance to battle the taboo about cancer.
الحمد لله هسه كل شهر بروح باخذ دواي ساعتين ونص 3 بكون نهاية كاملة.
The King Hussein Cancer Center is the only comprehensive cancer center in the entire Middle East. Over 100,000 visits every year.
يعني المؤسسة ما قصرت معي بإشي. فحوصات تعطوني العلاج المناسب وكل شيء. لما بقدر أوصل الحالة هاي.
We have no choice right now but to expand. There is massive demand from all over the region.
وهسه معي المرض الحمد لله بعلاجه بقدر أعمل أي شيء. والحمد لله هسه بتابع شغلي وتجوزت يعني وما عندي أي مشكلة. ومرتي حامل يعني. هسه هي بالسابع يعني كمان شهرين يخلصين عشان أشوف بنتي وأحضنها.
When a country is trying to develop, cancer imposes an even heavier burden on it. When such a large number of people succumb to cancer, you are losing a big chunk of the productive sector of society.
Most health systems in the world, especially in poor countries, are not investing enough in health. The costs of disease don't go away because you don't treat them. In fact, they go up. The cost in lost productivity, in lost human capital, they go up. That spending in health is not a consumption, it's not an expenditure, it is an investment. And that not spending enough in health is bad economic policy.
Cuando hay algún cáncer, son medicamentos muy caros que uno no puede pagar. Nos vimos al principio preocupados. Sin las quimioterapias no puede uno vencer esta enfermedad.
Blanca Estela Vargas.
Cuando me enfermé de cáncer de mama, me preocupó pues algo el dinero. Y ya me dice el doctor, aquí hay un seguro popular.
Es un apoyo para las personas que no tenemos otro seguro, otra atención médica.
Mi hija y mi esposo me arreglaron el seguro popular. El Seguro Popular se encarga de pagar esas quimioterapias tan caras. Es mucha ayuda.
The innovation of the Seguro Popular is to include cancer as a disease, so that there is no Mexican without access to free treatment for any cancer that they might get.
Today we were reaching 50 million Mexicans with Seguro Popular. I think that is affordable for any country, and I truly believe it's a great investment.
Me operaron y empezamos con las quimios. Hay un nuevo programa que ahora nos permite recibir la quimioterapia en nuestra propia casa. Terminan de ponérsela uno y uno, ya estando aquí en su casa, se acuesta uno a descansar. Yo creí que no salía ni el año pasado. Bendito sea Dios, aquí estoy de nuevo.
J'ai rencontré la première fois qu'on avait mis aux chimiothérapie qui est Francine. Moi aussi, j'ai resté avec une surveillance. Elle était gravement malade de façon qu'après avoir reçu les chimios ici, elle était au niveau que le pronostic était sombre.
Hari igihe nigeze gutekereza ko ntazakira, icyo gihe aribwo bwa mbere bampaye imiti. Indwara nkayirwanya kugira ngo ngarure imbaraga zo kugira ngo nkire.
Mais au fur et à mesure, elle a commencé à récupérer.
After the first chemotherapy administration, the tumor started shrinking, and I have, I think, photographs of every week. So we gave her 9 weeks of chemotherapy initially before the tumor was small enough for her to have surgery to remove the rest of it.
Les gens ont été étonnés de voir la masse diminuer. C'était incroyable, même pour le personnel de l'hôpital, parce que c'était pour la première fois.
Barayimaye ubwo bakajya bamfukura uko bamfukuye hakomokana nk'urunyama noneho hakajya ariyo kaba gatoya ubundi mbona ndakize.
One of the greatest outcomes of what we've done is that it's completely transformed the attitudes of the nurses on the ward. Now the attitude is kind of, okay, let's try, even when we see a really difficult case.
Ariko nyuma bigaragaye ko kuri ibi bitaro hari abantu bahakurikiranirwa bavurwa kanseri, hari abandi tuza tubona baturutse mu tundi duce tw'igihugu.
Et c'est pas Francine seulement, parce que dans ces 30 enfants ici, on a 12 enfants qui ont été guéris derrière lui.
Ndabifuriza ko bazarwara bagakira nk'ubundi nk'uko nanjye bampaye iyo miti nkakira.
We can learn a lot of lessons. Just a few years ago, we had no financing mechanism to diagnose, prevent, or treat, for example, AIDS in Africa.
People had said that we couldn't provide the care there. It was too expensive, it was too complicated, patients wouldn't come for care, there was stigma involved with the disease, and we couldn't make people better. And we've in fact proved them wrong.
It's a lesson we need to learn for cancer diagnosis and care, cancer prevention and care, is you need advocates.
When people started to actually live longer lives, people said, wow, this can actually be done, and everything changed. The same thing can happen with cancer. You're starting to see the treatment of cancers that people couldn't even treat in developed countries 20 years ago. They're treating them in these developing places. You have to just see those outcomes and show those to the world.
Every person has the right to receive excellent cancer treatment. Treating cancer should not just be an accident of geography.
So if we double down our efforts and continue to empower others to get involved, that is what will ultimately see cancer become a global priority. It's about sharing responsibility, and ultimately it's about taking action.
There's no more powerful testimony than someone in the community who was dying of AIDS or cancer or whatever else and now is better. That's all the publicity you need.
Nkunda kwiga Icyongereza, nkazatsinda nkaba umuganga. Nzajya nsuzuma abana barwaye kanseri.